Relax.
My patient, Mr. Pandey, 65-year-old laborer from Bihar, presented to us with a painless swelling since last 6 years in the left breast. This swelling has increased in size since last 1.5 months and was associated with pain and redness of the overlying skin over the left breast since last 1.5 months. For which he underwent some surgical intervention and pus was drained, tissue was sent for some biopsy was taken. He is also a known case of COPD. He is asthmatic since last 40 years on treatment for the same, and a recently diagnosed case of hypertension on treatment for the same. And he underwent open appendectomy 20 years back. And also he is a chronic tobacco chewer. And there is no significant family history.
It's not a bad idea to start after taking a deep breath and to present your case comfortably. You're all right, there's nothing wrong with your presentation because you covered up most of the points, but it was looking like you may go overboard anytime. So just relax about it, there's no need to worry. The positive history is actually a lump in the left side of the breast. Did it ulcerate at any point in time?
Yes, since last 1.5 months, it increased in
It
size.
was painless to begin with?
Yes, sir.
Became painful subsequently? Okay. Anything else that is going to be relevant in this case besides these points that you mentioned?
So
No
there's
history of
no history of hemoptysis, there's no history of bony pain, there's no history of anorexia, weight loss, and there's no history suggestive of any jaundice. And it's all in the
Let us assume for a moment it's not a case of carcinoma breast. Don't think about it straight away. If it's in your mind that it's cancer, then you automatically start taking a history very focused on that point. Just for a moment, assume that this is a case of a swelling of the left side of the breast. What can be the differential diagnosis of such a swelling in the male?
So it can be an abscess.
No, this is not a viva. You should think that way. Automatically you'll cover up those points in your history. The history is all about covering up those issues which are likely to be a problem when you're actually going to deal with it. Right? So what can be the causes of enlargement of breast in a male?
They can be a gynecomastia,
Okay, what are the usual causes of gynecomastia?
any drug intake or carcinoma.
I would say wherever there's a level of estrogen that has gone up, this can happen due to estrogen not getting metabolized or the patient taking estrogen. Okay, now estrogen not getting metabolized can happen in liver disorders. Yes, various. It can be drug-induced hype in the estrogen level also. These drugs are also hepatotoxic. So they act by the same logic. Okay, and patient could be taking estrogen. For which disease do they normally take estrogen? Males. That would cause gynecomastia. Now, how would this gynecomastia be relevant if it is unilateral or bilateral in this patient?
In these patients it is bilateral. Normally it is bilateral, but in this patient it is.
If it is a bilateral gynecomastia, what does it suggest? Systemic cause. Then that doesn't become a serious problem to you. Is it a precancerous condition, gynecomastia?
No.
It's not at all a precancerous condition. It is. Unilateral gynecomastia in men with Klinefelter syndrome is a precancerous condition for male carcinoma breast. So therefore it becomes important to be bothered about gynecomastia which is unilateral, confined to one breast. Is that clear? So therefore that history becomes relevant. Otherwise you can keep on asking questions pertinent to, we discussed breast yesterday, day before yesterday. So the same history can fit into this patient also. Mind you, it's got to be relevant to the case. Anything else you would like to contribute?
Any discharge, needs to be discharged.
Needs to discharge from the nipple. Makes sense?
Yes.
Okay. What's the relevance of a discharge from the nipple?
So if it's a bloody discharge,
Is it common with malignancy that you get bloody discharge or benign disorders?
Benign
disorders.
Which benign disorder?
okay.
Okay. So that's one thing. So discharge. Okay. Next. In the history of suppose now you start assuming that it's a cancer. Then you start taking history pertinent to the local site where the cancer is and its systemic or metastatic manifestations. Yeah. The metastatic manifestations of cancer would be what? It will involve bones, it will involve chest, that is lungs, liver, brain. So you have to give history relevant to that. So in a short span, you have to give more information rather than in a long span, little information. Now, no history of bone pains, no history of jaundice, no history of hemoptysis, no history of any convergence. What I am trying to tell you, that I know that this cancer can go to these places. That's the whole idea. Otherwise, you could say that the diagnosis is glaring. You are here to utilize this case or to use him as a vehicle to pass your exam. Now therefore you must be able to use it well. Use it well, you should know how it goes, how it drives. Okay? Okay. Is that all? Or any questions about that history? It's a short case. Sir,
I think that's sufficient.
could you move on to examination quickly?
So in examination,
We
my
discussed general examination in cancer patients
In three.
exclusively, so don't miss those points.
my patient is moderately built and nourished. His hydration is adequate. His hydration is adequate. His vitals are in the normal limit.
Performance test.
I told you 3 things are mandatory in any cancer patient, irrespective of what you like to talk about. Performance status, nutrition status, hydration status. Why don't I mention?
Performance test is adequate. He's doing his normal routine activities.
No adequate. There's nothing like adequate performance status. You have to score it.
More than 75%. He's spending less than 25% of the time with
Maybe we'll start with it.
Less than
What is that
25%
scale? What is that?
Karnataka scale.
Now, C score. Okay. Okay.
If he is spending less than 25% time in bed, that is grade 1. Grade 2 is from 25 to 50% of time is spent on bed. And grade 3 is more than 50% but less than 75%. And grade 4 is more than 75%. And grade 5 is almost
He's
all the
bedridden.
time. Yeah, he's
So
bedridden.
performance status is important. We discussed that performance status and nutritional status may not be linked. They are not synonymous. A person could have a good performance status and a bad nutritional status. You understand? It's vice versa is also possible. Okay.
So on examination, his right breast appears normal and left breast there is lesion approximately 5 into 4 centimeters in size involving the nipple areolar complex, and the overlying skin is erythematous. It is covered with scab and there is no active discharge present. Left axilla appears clear, appears normal, and the right axilla is also normal. There is no the nipple is retracted upside.
No dilated veins,
No
no
dilated
visual
veins.
pulsation. We discussed that. That's a routine. You would not miss it. Okay.
And on palpation, it is the overlying skin temperature is normal. It is not tender. It is fully circumscribed. It's involving the mass lesion involves the skin, overlying skin, and it is not fixed to the underlying structures. It is firm in consistency. It's hard in consistency, and it's irregular in surface. And there is left axilla. There is a single lymph node palpable in the center.
In the nipple areolar complexes,
It is involved and retracted.
Involved and retracted.
we discussed it yesterday. Dimpling
Dimpling
and
of-
puckering and pudorrange. Now, what is present here?
Since puckering is present.
How do you demonstrate puckering?
I will ask the patient to. This will the puckering
Is
will
there
be
any change in the levels now?
that yes, it has been detected.
How would you see that from there?
That we see.
Does it come in front, eyeball to eyeball?
Yes.
And you will know it. You don't have to measure this.
Yeah,
I don't think so. You can see that it's lifted up. What's the cause of this lifting up?
say involvement of the Cooper's ligament.
In this case,
In this case, involvement of the skin.
Involvement of the
what's attachment
fibrous-
of Cooper's ligament? We talked.
It is attached to the pectoralis fascia and to the subcutaneous tissue.
So in this case, they're fixed, they're together, so it will work automatically. Okay.
And
Which is more sensitive for malignancy, pudorrange or dimpling?
Dimpling is more sensitive.
Why?
Because even pudorrange is seen in some inflammatory.
Can be seen in some benign disorders like inflammatory diseases, breast abscess, etc. Because just the lymphatics need to be blocked. Subcutaneous lymphatics need to be blocked. And this is due to infiltration of ligaments of Cooper, so dimpling is more relevant. Okay.
so there is no supraclavicular lymphadenopathy present.
No, but let's see how you look for its fixity to the deeper structures. You just talked and ran through it.
Yes.
How will you look
So
for
ask
it?
the patient to hold his hand. Yes. पापा इधर आराम से रखिए ढीला
So,
छोड़िए
like we discussed yesterday, I was trying horse, look at this.
आराम से
Examine when the muscle is relaxed, make sure it is relaxed. He has done that. And now look for the mobility in 2 axes.
along the direction of the pectoralis major
Right. Good. Now make it taut.
अब यहाँ से ना tightly पकड़िए
Confirm that it is taut. Good. Now test. Fixed.
along the direction
Still it's free.
it's free
Okay.
आराम से
Now you would ask about fixing to serratus anterior, somebody was asking yesterday. Fixing to serratus anterior is very difficult to test. It amounts to fixity to the chest wall. The serratus anterior is the digitations of the ribs. So it is fixed to, it's not fixed to deeper structure, but skin is involved. Okay, fine.
Dilated supraclavicular lymph nodes are not.
Excellent. Now let's see how you examine the exam.
वाले डॉक्टर देखें
बाबा जी अपना हाथ यहाँ रखिए, ढीला छोड़ दीजिए, एकदम खराब,
Yeah, you just keep talking. You record as it is because he can't do it.
आराम से ढीला छोड़ दीजिए, वजन से छोड़ दीजिए.
Now, see the advantage of putting your, instead of making him drop it on your hand, you lift it on your forearm. It will be easier. You can use this hand on the other shoulder also, which you see in your books. But this is easier, as I told you, because you can actually use it as a counter. At the same time, the idea of not letting the patient topple over to the other side is achieved by this. Both.
So we examine the anterior central group, and the apical group, understanding.
What is the relationship of anterior group? What is in relation to what?
Pectoralis. It is present along the
What forms the anterior wall of axilla?
pectoralis muscles, pectoralis major.
So pectoralis
It is-
major is forming the anterior wall, it has to be in relation to
It has
pectoralis
to be.
major. What forms the lateral wall of axilla?
That's
Lateral side, lower side.
No.
But it's serratus.
Serratus
Serratus
is the
anterior.
lateral wall of axilla. So you didn't understand that also.
Maybe
Bicycle
it's
group
a-
of the use.
That's
Yes,
axilla.
sir.
Pectoralis major has to go to the lateral leg to form the anterior wall. Pectoralis major has to go medial to the medial leg to form the posterior wall. There's no choice but bicipital group to be the lateral level. And you often read in your book along the axillary vein. You can't feel the vein, so you have to feel it against the groove. So that's what the lateral wall is. What you're talking about is medial wall. Medial wall is serratus anterior, or the upper 5 ribs as they call it. The apical would be close to which space? Where is it?
Apex of
Where is the apex?
infraclavicular.
Infraclavicular where? They're all infraclavicular. Any relationship to the rib? Where would you feel?
First and
Against the first rib. That's axilla. How do you divide them into levels?
So we divide the axilla as in relation to the pectoralis minoris. If anything is lateral and posterior.
Anything is not.
If the
You should speak as you were taught.
If-
Anything means what?
It is divided by anatomical classification and by surgical.
Anatomically we have discussed.
Surgical is by the level of pectoralis minor.
Lateral to
Lateral
the
to-
lateral border of
Lateral
pectoralis minor level 1. Behind the pectoralis minor level 2, medial to the medial border of pectoralis minor level 3. And in between the two pectorals, rotatus group is also level 2. Is that clear? That's how we divide it for working purposes. Okay. Supraclavicular lymph node, if it is a node on the left side, it is still considered a part of the regional disease, no longer a metastatic disease. And 3 is very important. Anything that you want?
So I would like to see the abdomen. And I would like to see the right axilla also. And I would like to see the abdomen.
You see the right? It's normal? Why would you see that normal?
So I would like to see for any hepatomegaly, for bone metastasis, and there is a scar mark present, whether there is any incision.
Is there any bulge you could see here? So grossly visible? That's why I kept this case.
This is rib, lower border.
If there is a metastasis to the rib, it will feel like rib only? Would it or it would not?
But it will be painful.
Metastasis is painful or tender?
It will be tender.
What's the difference between painful and tender?
Painful patient will get tenderness.
Pain is a symptom, tenderness is a sign. You could easily ask him how long he's been having this. If it started before the breast lesion, then it's quite unlikely if he has it since childhood. ये कब से आपको ये जो पत्ती में सूजन है?
बहुत देर से पता नहीं है
Ever since he remembers he was born or he existed, it has been there.
and दर्द करता है ना कुछ
He's happy with that.
That's how you interpret the things. Interpretation is all very important.
I mean, this would look an obvious bulge. Anybody going to ask you. You should have asked yourself before we ask you. So what's the diagnosis now? I don't think there's any problem in diagnosis of these cases. This is all about examination. Right? Okay.
Diagnosis is carcinoma of breast, T4B, and
Stage is okay. T4A is what? Fixated to pectoralis major. T4B is fixated to the skin. And T4C, tumor. And T4D, good. Now, why do you say it's a carcinoma? That's a routine question that Professor Garg is going to ask you now, because he's getting ready into doing something with you. By this time, you should be prepared to answer those basic questions. And you can commit a mistake even here. Why do you say so?
So, because of the involvement of the
Question, what points in history, points in examination? And why don't you learn? Yesterday it was discussed so many times. What are the points in history? Old age, duration,
relations in the last 6 years, but recent also.
recent increase in rapid increase in size, fixity, involvement of skin in the last few 1.5 months or year, and on examination, art, love, involvement of skin, involvement of Nicola complex, presence of exuding influence. That's the end of the story. Don't waste time, your time, examiner's time. In history, they drag it. Points in history, points in examination. Always think about it that way. Okay? How do you confirm your diagnosis?
I'm getting FNAC especially
From where?
from the lesion.
If it is ulcerated, would you like to take a biopsy? Would you like to take a biopsy?
Yes, sir.
What's the gold standard for making a diagnosis of breast cancer?
Incisional biopsy.
True-cut biopsy, which is the type of incision biopsy. Core biopsy is the gold standard, although we do an FNAC mostly. Because it is less invasive and you get the information. What is it that you don't get on FNAC? Information that you don't get. What extra information do you get on true-cut biopsy?
Depth of invasion,
No.
hormonal status.
Receptor status, it is grade of the tumor. Okay? Time, histological time. It does help. Grade is important. It prognosticates the disease. Okay? Similarly, you can also find out about this receptor studies like ER status, P-glycoprotein, P53 mutation, etc. Particularly if you are going to put the patient on neoadjuvant chemotherapy. You would like to see the status before and after the chemotherapy, which can let you know about responders and non-responders. So, management,
So this is a T4.
would you do a mammography in this case? Yes or no, don't waste time.
Yes, sir.
Mammography in males is poor, very poor investigation. It doesn't do anything. You'd like to do an ultrasound of the contralateral breast. Basically, this breast doesn't need a confirmation. You need to know a lesion there. Suppose there was a lymph node on the right axilla, what would you do? You will try to rule out a lesion in the other breast. If there is no lesion in the other breast, it becomes a M1 disease. If there is a lesion in the breast, you stage it separately. The two different breasts are staged differently. It could be T4B N1 M0. This could be T1 N1 M0 or T2 N1 M0, depending upon the size. Or even TIS N1 M0 is possible. So it's important to grade, do mammography or locally. Is it a locally advanced breast cancer? How do you define locally advanced breast cancer? Anybody?
With the skin,
Any T4,
any
any N2.
stage 3.
Any T4, any N2. T4 N0 is also locally advanced. T2 N2 is also locally advanced. T1 N2 is locally advanced. The moment you have this, what is N2?
Same to one.
Ipsilateral matted lymph nodes or ipsilateral fixed to the axilla lymph nodes. Fixed to each other or fixed to axilla is considered N2. N1 is mobile. Okay, and N3 is supra. Would you like to give or probably treating?
So I would like to demonstrate the disease.
I didn't mention about metastatic workup which we discussed yesterday. You will do the entire LFT, X-ray chest, ultrasound abdominal, bone scan. It's mandatory in LABC, it's a part of the protocol now. Bone scan has to be done. Because you're calling it MX, which is good. You can't assess the metastasis, but then you should assess. You change the treatment. Metastatic carcinoma is a different treatment.
So I would like to demonstrate the disease. I will give him chemotherapy. Yes, I can see
Is there anything against chemotherapy, neoadjuvant chemotherapy in this patient?
it's a lesion. ulcerative.
Old man, performance status is poor. He cannot take up chemotherapy, neoadjuvant chemotherapy. Sometimes you do not take up the treatment should become worse than the disease. What's the upper limit of neoadjuvant chemotherapy? Age that you decide. One is 80 years age in the West, maybe 70, 75. In our part of the world, poor performance status. You don't want to kill him because of the neoadjuvant chemotherapy. So maybe upfront surgery and hormone therapy, depending upon the status. When will you give radiotherapy?
So if the patient is having bone status, bone involvement, bone
Will this patient require radiotherapy? Adjuvant?
So,
What's the criteria? That's what I'm asking. Most LABCs require it. Positive margins, they require it.
Just one.
Positive margins will require it. Chest wall infiltration they would require. And in patients where you have dissected axilla, more than 4 lymph nodes out of at least 10 that you have dissected are positive. Or if you have dissected less than 10, you have to give it. If you have dissected 3, you can't say 4 are negative. Then angiogenesis, lymphovascular indication. These are the indications. Poor grade. So you would require adjuvant radiotherapy. Maybe you require to provide a skin cover. If you can you put a graft if you resected and skin loss is major? The graft is bad because you have to give radiotherapy subsequently. You need a flap. You need an LD flap or a local flap which can be rotated. The flap can be rotated based on perforated intercostal artery. It's a laterally based flap. The place from where you take the flap can be replaced by a skin thickness skin graft. But the site has to be covered with a flap, which should be able to receive radiotherapy. Is that clear? Any questions? Adjuvant hormone therapy would depend on the estrogen receptor status, and most of them get it in respect of the estrogen receptor status in our part of the world, because 10 to 15% still respond. What is the hormone therapy you get? Tamoxifen. Side effects of tamoxifen? He can't have it. Can you have it? Heart flashes, osteoporosis, pathological fractures, thromboembolism, old man. So aromatase inhibitors are found to be better. What is the neoadjuvant chemotherapy regime that you can give to the patient? CAFB, side effects of cyclophosphamide,
ECG,
hemorrhagic cystitis. All of them cause bone marrow suppression, hemorrhagic cystitis. Adriamycin is cardiotoxic. 5-FU is bone marrow suppression, preoperatively. Okay? Any questions?
Radiotherapy, post-operative radiotherapy, that depends on the size of tumor.
I just told you. I mean, locally advanced would be size included. And positive margin, infiltration of the chest wall. Again, it will change the stage. So basically, let's stick to the stage. Size is considered in the stage. Clear? Thank you.
So, locally advanced, we can define as a stage 3 body tumor, or we'll decide.
You can say that. Actually, not. Some people take 2B also. Some people take 2B.